This is week 14. I can't believe it. I'm going to be sad. Aren't you going to be sad when it's all over? No?
Yes and no.
I mean, you guys have been you've been a lively group, so I'm kind of excited now for you. No, I think you know what, this next part of the courses that you guys go into, and Darcy, you're doing the coding right together, aren't you?
Yes.
You are? Oh boy, wow, you're brave.
And working full time and have 2 kids. Not easy.
Word. Well, you know what's good for you is you have really a complete year. You have all the way to the end of 2016 to complete the coding. So that's kind of what's great about when you guys are started the course, is that you have that option of being able to go throughout the entire year to be able to graduate and sit, not just graduate, but also sit for the National Boards exam. So that should give you a little bit of comfort, because you really want to make sure you're prepared. Okay.
I was kind of nervous until last class with Doreen, and I thought we were going to have to take it right after the class ended, and I was like, oh no, I don't know if I'm going to be able to.
You know what? I apologize, because I really should have said something to make sure you guys knew kind of how that works, and that's probably my fault. I probably dropped the ball, or either that you had so much information provided you know, didn't hear it. So, but I usually like to repeat that kind of stuff because it's important. It's a little different for CMAA, the medical office specialist, only because, you know, the course is geared to passing that particular program. So it's smarter to take the test right away. So it's a little bit different. Okay. And we do offer that right after the program's done. So, anyway, I'm really proud of you guys. You've come a long way, and I'm sure you're like, phew, like, get that off my back, right? Because I think this is one of the hardest parts, is learning, getting a medical vocabulary is so tough. But I think that you will find that this is going to help you, and I think you'll refer to this book a lot more than you probably anticipate you will be. I referred to it a lot when I was new in the medical field. Mind you, I had a different book, and we didn't use Google like you did. I'm sounding old. Oh my God, I'm ancient. We didn't use Google at work. We weren't allowed to back then. So, yeah, that's right. I'm old, all right? Just going to say I'm old, and I remember the day. My daughter one time pulled out not a cassette player. What was it? Oh, a floppy disk. You probably don't even remember them. You maybe saw it in school when they talked about what it used to be.
No,
But
I used them.
the little hard
Computer, yes, and we played Oregon Trails.
Oh my gosh. Okay, so that's hilarious. So my daughter, it was like in we were doing something for her school, or a fundraiser. Oh, she was doing a people-to-people trip. So we were doing a fundraiser for her. And we gave her one of my husband's old, kind of like a lock box for putting money in. And she lifts the top of it. You know how it has, you put the change on top and then the dollars on the bottom. So she lifts it up to see what was under there. Any teenager would. And she's like, what? There was a whole bunch of those floppy disks in there. She's like, what is this? And you could have seen the look on her face. Like, what did you use that for? Why would you need that? That made me feel old that day. So she was punished. I took all the money. No. But it's just so funny how things have changed. My God, when I went to school, we had one computer at the end of the hallway. And I think that was in high school, for crying out loud. All right, so let's do our last set of drug words. Yay. I know that was your favorite part. You probably want one more week just for, fun, but one more set and then you're done. Number 1, clozapine. 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 Number 2, Flexeril. Flexeril. Number 3, heparin. Heparin. Number 4, hurricane spray. Hurricane spray. Hurricane spray. Number 5, lactulose. Lactulose. Number 6, lisinopril. lisinopril. Number 7, Omneris. Number 8, Provigil. Provigil. Number 9, Tegretol. Tegretol. And number 10, Focalin. Focalin. When you figure out what that is, just know that I probably should be on it. You'll have a little chuckle to yourself when you're doing it, okay? Put a little asterisk number next to it. Any of those you want me to repeat?
Number 3 and 7, please.
Okay, 3. Heparin. Heparin. And number 7, Omneris. Omneris. It's kind of funny. It's got a nose on the commercial, and it runs around and says Omneris to the rescue. That might help you. Okay, so this week we're going to do 14 and 15. The reason I'm doing 15 is, well, first of all, 14 is so short. Obviously, a little bit of anatomy, not much with the ear. But also 15 is kind of like a repeat of a lot of the stuff that you've seen, because it's talking about your glands and stuff, and you know, metabolic stuff. I mean, it's a lot of repeat, and I felt like you don't really need a whole week on it. I think that putting these two together should be fine. And what will be great is that we can come back next week. It can be a lecture geared just towards what happens now, and that you can focus just on that. So I prefer to do it that way, and you know, it allows us to have a full 2 hours if we need it next week, or to make it however we need to make it for us and you, okay? So let's start in with chapter 14, the mastoid process, ear and mastoid process. I'll give you the anatomy that you need to highlight, and again, it's not very long. As you can see, it's only 2 pages or so. So on 565, first of all, you need to know that you're learning about hearing and also the sense of balance that comes with that, because your equilibrium is based on your hearing. You ever hear somebody that's having hearing problems and then all of a sudden they have equilibrium issues? So that's what you're going to be focusing on a lot in this particular chapter. A couple of real medical issues that you'll see here affect a lot of people. So you'll see that as we get going. So the first thing you'll highlight is the mastoid process, which is there. I would highlight just its definition, which is that whole sentence there. And then it talks about where it is, that it's located behind the opening of the auditory canal, which usually you hear external auditory canal in a medical record, which is just the tube that runs from the outer ear to the inner ear, or middle ear, really. You may know it as the tympanic membrane, or they call it a TM. So typically that's what we hear is ears. They'll say ears, TMs, clear. Okay, so, and this would be in the subjective statement in the medical report, okay, under HEENT. We usually hear with this mastoid process in the auditory canal, we usually hear a lot about it because of the chronic mastoiditis in adults. So you see it a lot in adult. Okay, so the next thing you guys will highlight will be the auricle, but it's also called the pinna. And I'm going to say that you hear auricle more than the pinna. That's the visible part of the ear. Okay, I want you to turn the page. Now, you refer to that diagram as a great diagram on that page on 565, so make sure you do refer to it. I'm not going to have you highlight the crura. It's just the upper part of the auricle. Okay, highlight lobule though. You hear lobule with the lung lobule, the liver lobule. So you will see this again, but here in this case, they're referring to just the earlobe. The next one will be the auditory meatus, and the definition starts at the beginning of that paragraph. So highlight the whole thing. The key to it, though, is highlighting or making note of the opening of the auditory canal. So auditory meatus, and you've seen meatus before. Meatus we've seen with when we did the urinary system, when we did the genitals, we were talking about the urinary meatus, so you've seen that before. Okay, cerumen, that's just earwax. We hear that with cerumen impaction. So it would be considered a diagnosis. They typically would prescribe something like Debrox, which is like an ear wax removal thing. They can usually get it over the counter. Sometimes, especially in the elderly, they may need to do it themselves. And I'm sure that the doctor is thinking to themselves, that's not what I went to school for. But it happens a lot. And you think about the elderly, population, and some of them aren't able to do things like that. So that's actually quite common. So, all right. So the bottom of the paragraph where it says, about 3 lines up, you guys, all the way to the right, starts the sentence with, because the membrane is extremely delicate. I want you to highlight the whole rest of that. That's just a good reading there. Oh, I have one more thing. Sorry. Tympanic membrane. Gotta highlight that. Eardrum. Vital function of the human ear. And what that does is it amplifies the vibrations. So it's a little membrane. Pay attention to your note. For those of you doing coding, your note on the top of 567. Now, you'll notice they're breaking it up. Now they're going into the middle ear here. For me, I don't think it's as important that you guys be able to distinguish between, the outer and middle and, inner ear and things. That doesn't concern me. More the vocabulary that is based in this chapter is more important. So keep that in mind as you're learning. The eustachian tube would be the next thing. Common problem is called eustachian tube dysfunction. See this a lot in children. So depending on who you work for, keep that in mind. The function is helpful to highlight, which is the last line of that paragraph. Supply air for sound conduction and pressure. It also stops the eardrums from bursting. Like if you go in high pressure areas and things like that. So if there's an infection in the ear, this is usually the tube that gets infected before it goes further. So that's usually the first thing that gets. That's why we see so much of it with children. Eustachian tube dysfunction. Okay, so all this next section, everything in here I want you to highlight. Ossicular chain, not so much, but the ossicles, malleus, stapes, and oval window. Again, those are all terms. So if somebody's having an infection or an issue with any of those, they'll be referring to some of this stuff. I'll give you a little bit of stuff if you want to just write some notes to yourself or what have you. The ossicle just transmits sound, like the sound vibration. I shouldn't say sound because it is the vibration. The malleus, increased loudness of the sound. So as it's entering the ear, it increases the sound. That's what the malleus does. The incus is just a connection between, the malleus and the stapes. So it's nothing real important there. But stapes, what's interesting on that one, when you look at, if you highlight that, it says stirrup. That doesn't mean anything to you. But it's the smallest and lightest bone in the human body, that stapes. I've always found that to be interesting. So the oval window, what's kind of neat about that is by the time that the sound has hit the oval window, that sound has already been amplified 20 times, since then. So it's already very loud as it gets to it, that oval window. Okay, you got your be carefuls that you'll pay attention to. Into the inner ear, again, don't worry about the distinguishing between them. Highlight the labyrinth. That's the inner ear. That provides hearing and balance. So when I say like the equilibrium and the balance and stuff, it's your body's way of, it's also like pressure, like dealing with pressure, air pressure, or all kinds of different things, like movement or pressure, I should say. Okay, so don't just think of it as, oh, I'm standing upright and it's keeping me in equilibrium. It could be all kinds of different things. Think of when you go up in an elevator or when you're going up mountains, things like that. Okay, so highlight the perilymph. You will see that as well. Perilymph, endolymph, both of those. For the perilymph, I would just highlight just before it, and same thing with the endolymph. So those two sentences there. Okay, so vestibule will be the next thing. It's kind of like the central part of the inner ear, but it helps detect like if an accelerated movement. So think about it like in a car, like and you accelerate really, really fast. That's kind of what that's doing. It's helping detect all that kind of stuff, things that's going on. The next thing you'll highlight will be the cochlea. And I want you to highlight the sentence that goes right after that, all the way to where it says equilibrium. That's a lot of good information about what those things do there. Their function. The crista ampullaris, I'm not going to say something to memorize, but it's just good information. I know it's on some of the homework and stuff. And I will tell you the definition before it, where it says a semicircular canals detect dynamic equilibrium or a sense of sudden rotation. And it's through the function of this particular thing. I wouldn't memorize it. You're probably not going to see it unless you're dealing with somebody who deals with, an ENT doctor. Let's just put it that way. Then you may see something to that. But as far as this goes, I wouldn't worry about it. So it deals with rotation and rubs against the hair follicles and hair cells. So that's how it functions. Organ of Corti, again, another one that I wouldn't worry about. That's again, that picks up vibrations. Vestibulocochlear nerve. What that does, that nerve sends information about sound and equilibrium or your equilibrium to the brain. So that's kind of like, well, think of a nerve. What does a nerve do? It's sending information anyway, but that's what its main function is, sound and equilibrium and sending all that information up to the brain. So when I was talking about like the hair cells and stuff, how the sound is brushing against those hair, that's it. Depending on how loud some noise is how many hairs move in your. Isn't that kind of scary? It's like, oh wait, I have hair inside too. Yeah, that's basically it. All right, so 568, all your homework and your Evolve exercises. Evolve was down today, but I think it's back up now. And then you have your combining forms on 569. Not too much in the way of anatomy, so that should be pretty easy. Macrotia and microtia you should learn together. Talking about abnormally large auricles, the ear, or small. That's all I would know. The microtia is a congenital disorder. Very few people have it. Children are born with it. And actually, you could be born with one or both of them being small. So it's not, don't just think of just small ears for somebody. It could be both. Okay. External ear cholesteatoma. This is cystic mass. It's a keratin accumulation, which you'll see in some things. And it accumulates usually in the tympanic membrane. That TM I was referring to earlier, that they always talk about in medical records, that's where that accumulates. So there's usually something like this where you have this accumulation of this cholesterol. It can be brought on acutely or it can be brought on over time. So it's one of those like congenital type thing or chronic. All right, so exostosis of external ear. Think of this as, because it's usually termed surfer's ear. So somebody who surfs, somebody who's always in cold water, it's this buildup. So what happens is like the wax and the water get blocked in this ear, is what's happening. So I want to be clear, it's not the same as swimmer's ear. You know, if you go swimming and you have swimmer's, this is different. This is surfer's ear. It's different. And if you look into it, you'll see it's a little bit different. They talk about a bony growth. You don't have that in swimmer's ear. That's just really clogged water. Otitis externa, that would be what you'd call swimmer's ear. You'd usually be given ear drops or something for that. Earache and stuff that you get from it. So we see that an awful lot. Perichondritis, and again, it's auricular perichondritis. Just an inflammation of the perichondrium of the external ear. Usually you see this with like contact sports, and they typically give you antibiotics. So stenosis of external ear canal, and again, this is an acquired one. This is uncommon, so we won't worry about it. Ankylosis of ear ossicles. Ankylosis means hardening. You've seen that before with other things. Usually associated with something called otosclerosis. So stiffening of the tiny bones of the ear that we were talking about earlier. That was in that middle part of that ear. Cholesteatoma of Addick. Don't see that one. Don't worry about it. Eustachian salpingitis. That one you can break down. You'll be fine. Inflammation of the eustachian tube. Mastoiditis you should be able to break down. Again, you'll be learning what the mastoid is. Usually this follows a condition called acute otitis media. So the patient typically comes in with that, and this will follow alongside that. So one of those secondary conditions, if you will. Meningitis, again, another one to break down. Oh my gosh, this is wonderful. And then otitis media, back to what we were just talking about a little bit ago. Otitis media, inflammation of the middle ear. And I want you to pay attention to, in the definition, it says suppurative and non-suppurative. You will see those. They will say suppurative or non-suppurative. Typically, it's suppurative, okay? So this usually comes on really quick, and it's just an accumulation of fluid in that middle part of the ear. Patulous eustachian tube. So basically a person would be talking and hearing themselves inside their head. So it's like this external noise that you're hearing, or external, I should say internal. You're hearing yourself talk inside your head, which would drive anyone crazy. But it's like, breathing they would hear. I mean, your heartbeat, things like that. I always found it interesting that in that particular condition, it was sometimes associated with weight loss too. Somebody was losing a lot of weight. Things like that would happen. It's kind of weird, but perforation of tympanic membrane. Well, what does perforate mean? So puncture of the eardrum. It's kind of a give me. It's basically a hole in the eardrum is what that is. You may end up with hearing loss or drainage into the ear. But typically those kinds of things, perforation, depending on how bad it is, can heal on their own. So usually it's not too bad. Petrositis. Again, another one that you may see with otitis media, but you don't see it very often, so I wouldn't spend a lot of time on it. Tympanosclerosis, abnormal hardening of the eardrum. This is basically calcifications of the tissues in the middle ear. So little hardening, little pieces really is what's happening in this. That's what sclerosis means anyway. It's kind of like hardening. And that's how you'll see that, or what it would be like. Okay, you're gonna do the homework, and then getting into diseases of the inner ear now. Oral. I reminded you last time we talked about this word, oral versus your oral here. Make sure you know the difference. Yeah, I used to drive. I had a student one time. She kind of became my buddy for a lady that I ended up hanging out with afterwards. But she's like, "How come you sometimes write in cursive and sometimes you write, regular handwriting?" And I'm like, "I have no idea why I do that." So if it drives you mad, just know it's driven other people mad too. I don't know. My brain just works that way. Okay, so vertigo. Frankly, they'll always say just vertigo, okay? And again, things may be changing now that we're getting into ICD-10 and they're being so persnickety about these things, but it's always been termed vertigo, a sense of dizziness. You can feel like the world is spinning around you or that you're spinning in the room. So it affects people differently. The length of time that someone has this varies. It depends on the person and how bad it is. I've known people that lived with it for 6 months plus. And it just, terrible. It can incapacitate people. So you'll definitely see this. It's kind of a scary condition in my opinion. Typically seen with a condition called Meniere's disease, which is coming up in 2 words here. So it's typically seen with that, associated with that. And I also just want to caution you that there are different types of, in other words, like this benign, what's it called? Not prosthetic. It's like positional vertigo. Like somebody has the dizziness when they're in certain positions. So you'll see different types of that. Labyrinthitis, inflammation of the labyrinth, which is in the inner ear. Someone would end up having severe case of vertigo in this condition as well. Typically seen with somebody this follows a person who has had an upper respiratory infection, can typically get something like labyrinthitis. Meniere's disease, again, a chronic condition, vertigo, hearing loss, all that kind of thing. People that I know that have had Meniere's disease do end up with hearing loss, or have ended up with hearing loss for sure. So it affects your hearing and your balance, both things, in this Meniere's. So people get really sick, nausea, vomiting, as you can imagine with the vertigo. And it typically just comes and goes as well. The hearing loss, anyway. Autosclerosis. This is an inherited disease. More prominent among Caucasians versus any other ethnicity. Again, a condition of hardening of the ear. So you see where it says development of a bone. So it's this hardening. It's kind of like the surfer's ear where it gets this hardening in there. So autosclerosis you may see. Vestibular neuritis, inflammation of the vestibular nerve. So now we talked about what does the nerve do, transmits that information to the brain. So that, as you can imagine, that can cause a lot of problems. It can come on all of a sudden, so it can be paroxysmal as well. Okay, so conductive hearing loss, all kinds of causes for that. Again, trauma and things like that. what they do is they do a tuning fork test to test this. And like there's something called the Weber test that you'll see coming up as well. And that's how they'll check for it, is, because it's localized to that particular ear. Diploacusis, again, another hearing loss. What happens here in this one, it's pitch perceptions, the pitch of the noise. And this is a type of a condition called tinnitus, which you'll see and is very common to have doctors in a medical record say if the patient has tinnitus or not. So that's one of those conditions. Remember I've said to you before, in the subjective statement in the history of present illness, when a doctor is seeing somebody, they'll say the patient complains of this, of that, of this. That's one of those things where they'll say no, I guess I don't really need to write it, but no tinnitus. I'll write it down, I guess, because you don't see it now, but no tinnitus, or the patient complains of tinnitus. So that's not just a diagnosis, in other words. It's usually seen in the history of present illness, whether the patient's having it, complaining of it, or not. Okay. Okay. Hyperacusis. See this with musicians a lot, hyperacusis. Somebody has this, they'd have a hard time with attending very loud events. Otalgia, pain in the ear. That's just an earache, so you can just highlight earache. I mean, there's all kinds of causes for that too. It could be infection, it could be all kinds of things. Impacted teeth, sinuses, things of that nature. Otorrhea, a rapid discharge of blood. So that's a hemorrhage, if you will. If that's easier to just mark it as hemorrhage from one or both ears, that's what I would do. Otorrhea, discharge of the ears, that's what I would highlight. Again, that's another one you see with that otitis media, and also referred to as OM, as you saw when they were giving you that word. And they sometimes refer to it as OM, but typically, because it is a diagnosis, it's usually written out. Okay, ototoxic hearing loss. This is a drug-induced hearing loss. So it's toxicity to the ear. Presbycusis. Do you remember last week when I taught you a cute little way to remember presbyopia? Remember we talked about Presbyterian churches? Here you go. Now it's one for your ear. So you have old age hearing is what that is. Sensory neural hearing loss. Better make sure you know this one. You will see it. So this can happen to somebody who's been exposed for long periods of time to loud noises. You think of machinists. You think of people who work in plants. Anything where there's a lot of noise, on a regular basis. They typically see that. Tinnitus, I told you again, you want to make sure you will see that. It's a ringing, a buzzing, an abnormal sound that's constantly heard in the ears. So it's not like they're around ringing, buzzing, it's just happening around them. So they can be in a quiet room and still hear that. Can cause somebody to go crazy, literally. Most common cause would be just, regular hearing loss, noise-induced, I should say. All right, transient ischemic deafness. You've seen transient ischemic attack. Do you remember the TIAs we learned, the little mini strokes? So here's transient ischemic deafness. So it's, again, the same similar thing to stroke. What causes a stroke? This is causing the hearing loss. Okay, acoustic neuroma. They think that this has to do with a gene defect, which is why people have this. This typically affects women. So again, I don't know where the information comes from, but that's what they're basing it on. Because it's like an abnormal protein that grows. And it grows really slowly and over a long period of time. So this tumor grows in the ear. Ceruminoma, very rare, so you're not going to worry about it. Okay, don't forget your PCS guideline alert for those of you in coding. Diagnostic audiology. So these are procedures of the ear that we're into. Diagnostic study of the ability to hear. They're usually doing this with people with defects, hearing defects. Can treat, I should say. Audiometry, process of measuring hearing. So what they're doing is they're measuring the level of, and I hate to use this word deafness, but that's really what they call it. Level of deafness. How well can you hear? So that's what you remember putting on the earphones? That's, and they do that where you have to raise a finger and where you're hearing it. That's what they're doing. Cochlear implant. So what happens is that the sound bypasses the middle ear. And this has been unbelievable technology, and it has helped so many people hear for the first time. So it's kind of exciting. And you're going to see a lot more of this. Electrocochleography. Remember that Meniere's disease that we just passed over a couple of pages ago? This is a test for that Meniere's disease. So again, another one that you will see, ECOG. Mastoidectomy, I think you should be able to break that down. They're taking out the mastoid air cells. So it treats it. This is actually treatment for a couple of different things, otitis media and mastoiditis and a couple other things. So another one that you will see. Laryngostomy, again, another one you should be able to break down. So what they will do this for, why they do this, is to prevent recurring condition. That whatever is going on, they're going to try to prevent a recurrence of it. So they will go ahead and do this. Laryngotomy, in that they're actually going to insert a tube. Okay, ossiculectomy. Another one you should be able to break. Most of these you should be able to break down, almost, if not all of them. So the treatment of ankylosis of the ear. So they do this to treat things like vertigo, that cholesteatoma. Otoplasty, that is a cosmetic ear surgery, so I wouldn't worry about that, okay? Otoscopy, they do this typically to treat that, or to diagnose the otitis media that I was referring to, that you will see a lot of. Paracentesis of tympanum, surgical puncture of the eardrum to drain fluids. Again, it's from that otitis media. I would just, if they usually use the word aspirating when they're removing fluid. They don't usually say drain medical records, they'll say aspirate. Stapedialysis, definition's fine, helps to restore hearing. Stapedioplasty, again, that definition's just fine. Can be done by laser, though, which they're doing a lot more procedures with lasers. So you're going to see, even beyond what you learn in this class, you're going to be seeing that change dramatically over the next few years. I've seen it so much in just like the couple editions that have come out in the last couple of terminology books. And I review all the terminology books from all the companies before we go with certain ones. And it's so funny how much they've changed, and they're all consistent. Treated with laser, treated with laser. So you're going to see a lot more of it. So be ready for it. Tympanometry. It's not really a hearing test, so I kind of make note of that. It's not a quote-unquote hearing test because it says a process of measuring the eardrum. It's testing the function more so than, a hearing test. And again, it's used to diagnose that otitis media that I was mentioning. You see quite a bit. Tympanoplasty, reconstructing the perforated eardrum. And what's kind of crappy about this particular thing, it's not always 100% effective. I don't really know many procedures that are, but they mention that an awful lot. Like there's a risk factor. In other words, not going to work. Universal newborn hearing screening test. It says newborn, so they're testing these young children. It's becoming more and more popular. So even if you don't see it now, lots of doctors are starting to encourage it. So depending on what kind of doctor you work for, you may see more of this. And they're looking for early detection of hearing loss in children. Okay, so abbreviations. All of those you pretty much see. Not really the OAES so much. Not really the ABR either. Again, making note of, they gave you the couple abbreviations that are, not really encouraged to use. I'm going to tell you that they still do quite a bit, but you should be very careful in using them if you do use them or what have you. All right, so that's the ear. Nothing to that chapter. And again, I'm going to say the same thing. Look at 15 as kind of a recap. I told you the end chapters of this book were, it was like, oh my gosh, I know you worked so hard. Here you go. Here's the easy stuff. And this is a recap of so much of what you've learned already. And I think you'll be pleasantly surprised. The first thing that you'll highlight is the, just learning the functions of the endocrine system. I'd like you to really read through that. As far as memorization goes, I wouldn't worry so much about that, but I do want you to read through it. Good information. And then they get into the anatomy and physiology, which is really going to be on the next page. But this is a great diagram to show you where things are and the stuff that they'll be talking about. The glands in your body. A couple of brief notes before you go, though. So I want to talk to you, pituitary gland. All the things on the next page, 587, are secreted by this little pea-sized gland. Now, I don't want you to get all worked up about all this stuff. What I want you to know about the pituitary gland, its location in the brain. And it's this little pea-sized gland, like I said, small thing, protected in the depths of the brain. And it has functions on the front of it, and it has functions on the back of it, okay? So that's what I always found interesting, is how many things that this does for us. So it gives them to you all in 587. Yes, I think you should be aware of all of these different abbreviations. I'll tell you why. When somebody comes in complaining of, their thyroid, they're going to do a TSH. Yes, I know your thyroid is a gland as well, but this is in your follicle stimulating hormone. I mean, in your pituitary gland. So you will see them test for that, a hormone in your brain, not just a hormone from your thyroid. So I do want you to be familiar. I don't need you to be able to tell me like what FSH stands for or LH. I don't care about that, okay? And I'm going to tell you some that you don't really need to know. Or let me give them the ones you should, I guess. On 587, the abbreviation ACTH, you'll see, which is under the adrenocorticotropin hormone. You do see FSH, okay? You do see LH, growth hormone, so GH, HCG, The word prolactin, not the abbreviation, and then TSH. On the next ones down, the ADH, and then they will say oxytocin. They won't use the abbreviation. Okay, so do I care that you know these are secreted by the front, these are secreted by the back? No, I don't really care so much that you know each effect, like what does each hormone do. I told you what I really care about is that you're familiar with these abbreviations, that you know they're secreted by the pituitary, you know the location of the pituitary, and I think that that's about it. Those are all the hormones that they release. Okay, that's kind of fair, right? Not too bad. Okay, getting into, you got to be careful, don't forget about that. Thyroid. And again, refer back to the first page where it shows you where the locations of these hormones are. So your thyroid controls how sensitive your whole body is to hormones. So it really does affect a lot. So anyway, I want you to highlight that. I think the location is important, which 2 sentences down tells you its location, anterior or the front part of the neck. What it does, its function, regulates metabolism, controls the amount of calcium, which goes into your bones. What happens is it actually ends up taking on the iodine and allows your body to absorb the iodine. Uses it, in the hormones. So I would also highlight here, they give you a couple of, the secretes, with the types of hormones. In that little section, do you see that? Calcitonin, T4, but it's also called thyroxine. So that's one where you may see T4, you may see thyroxine. Both of them are used interchangeably. And then T3. So they won't ever say those out. Doctors can't pronunciate them either. So those are all labs. Okay. You'll notice just above there's that TSH, which goes back to, what you saw in the pituitary gland, but they talk about the TSH here. Okay, so parathyroid glands, 4 small glands surrounds the thyroid, and it secretes the PTH. So what it does is it's just regulating calcium and phosphate levels in the blood. You can almost go through in this chapter and just go location, what's the name, location, and what does it secrete. It's okay to learn the functions. I don't think it's mandatory for you to learn them, but if you want to educate yourself about your body, I think it's helpful. Adrenal glands, also referred to suprarenals, and I tell you, I think adrenals is used more than suprarenal, but it does help you with the location above the renal, around the kidney. Okay, let's see if I can make your life easier here. So they talk about the adrenal cortex and the medulla, talking about the outside and the inside and the hormones that it secretes. I don't care so much about that. What I do care about is the words glucocorticoids, mineral corticoids, estrogen, androgen. Go back into the EEGs of the other 2, cortisol, hydrocortisone, and aldosterone. You will see those. I care about dopamine. I care about epinephrine and non-epinephrine. These affect our growth, our development. I mean, these are critical. Your ability to handle stress is from this particular gland. So, have you ever heard somebody say their adrenals have been taxed? Or for somebody who's not sleeping well, there's something called an adrenal cocktail. It's like, I think it's like some sort of salt that you drink with like orange juice or something like that. And it's supposedly supposed to make you asleep. It's like 3 things you put together. And my husband and I were desperate to sleep, so we actually did this adrenal cocktail. You'd think I remember what it is. All I know is the salt. I think it was Himalayan salt. And like all this stuff I would never drink or eat ever in my life, like orange juice for one. Like I don't drink that. I don't take salt. So it was really bizarre, but it totally worked. It was weird. I don't know. So anyway, want to learn more about adrenal cocktail? Look it up on Google. Okay, so what else? Okay, I want you to know pancreas. Helps you to digest and absorb nutrients. So this is a very important gland, as you can well imagine. It's considered a digestive organ for that reason. So it's the back part of the stomach. I'd like you to highlight a couple of things here. Insulin, first of all, it's very important. You guys know, I'm sure you've seen diabetes mellitus and insipidus. So insulin is something that we talk about an awful lot, or you'll see in the medical field. I want you to highlight the very last sentence because it's just good information, what it does, its function. So it talks about the very last 2 words. It talks about insulin and glucagon, what it does, its effect. I'd like you to highlight ketones in there as well. Pardon me. And that's it. Okay. Thymus gland on page 591. Location, mediastinum above the heart, so in the center of kind of like the chest area. And the hormone it secretes is thymosin, which is almost below the word thymus. Deals with your body's immune response. Ovaries and testes, this is kind of a review because we covered it all with the male and female. So ovaries, testes, and males, that's the gonads. Females and males, gonads. All right, so it's just dealing with your reproductive functions. You guys know the hormones that it secretes. Pineal body, that might be a new one for you. Some people refer to it as the third eye. You may have heard of that saying before because it relates to psychic ability. But anyway, this is in the center of the brain, and it deals with hormone melatonin. So melatonin and serotonin are your like wake sleep hormones. So again, you hear a lot about that. A lot of people have problems with sleep, with all the stress that's going on in today's world. So melatonin is discussed at the least in a medical visit. Okay, so getting into all the different things that you all need to know. I was kind of bummed in that particular, I know it's repeat information, but you should go back and remember what ovaries and the testes, what they secrete, okay? Talking about the testosterone and estrogen, progesterone, make sure you know those. Okay, all the conditions, again, all repeat stuff. And the definitions are fantastic here. Anorexia, now, again, there's 2 types. Anorexia nervosa is the neurological condition that the person won't eat, whereas this is something that we see all the time, people being sick, especially with the flu. So you will see this with anorexia times 2 days or however many days the patient didn't eat. Glycosuria, that's the amount of glucose in the urine. Hyperelimination, excessive intake of food. I wish I could do that right now because I'm starving. But obviously this is a little different. It would be, again, kind of like a neurological condition, overeating. A lot of people do that with, they call it, what do they call it? Kind of like binge eating, yeah. But this is more like, well, yeah, it's kind of like binge eating. I guess you'd say that. There's another word I was looking for. Can't think of it though. Hyperglycemia, excessive glucose in the blood. Ketonuria, ketones in the urine. Why that's important, again, they're looking for malnutrition. They're looking for that diabetes mellitus. Remember that diabetes mellitus is seen a couple different ways, and that's very important. It's remember we saw the IDDM and the NIDDM. We typically see it as just DM, and then they'll say type 1 or type 2. But that's very typical, and I just want to make sure that you remember those because it's kind of important. Paresthesia, abnormal sensation, and they give you example, prickling. Polydipsia. Now, paresthesia, polydipsia, polyphagia, polyuria, those are terms you typically see, and again, the history of present illness. Okay, so again, they rule things out and rule things in that part of a report. So make sure you make note of that. Okay, pre-diabetes. Somebody who, they'll say pre-diabetic, okay, and this will typically be somebody who's overweight, okay, is usually on there. They'll be looking at their blood work, okay, and usually the plan would be they'll tell the patient that they're going to have to exercise and remove sugar from their diet. So we have an awful lot of diabetics, never mind pre-diabetic. This is a common diagnosis now, pre-diabetic. Sometimes they'll even go as far as, in like the physical exam, when I said they sometimes do a general, who is this patient? Like, oh, this is a thin, white, 27-year-old female who comes in today, complains. But in the physical exam, they'll just say, they'll say, what is it? Well-developed, well-nourished white female in new acute distress, okay? Like a general statement that you look okay, don't look like you're in pain. And then sometimes when somebody comes in with this pre-diabetes, they go, this is a, well-developed, well-nourished, overweight, pre-diabetic male, that's typically like they're describing that, oh, we should be careful. We have to look at other things as we're doing this physical exam. So that kind of cautions the doctor to look for certain things, which is why they kind of explain how you look. Keep that in mind when you go to the doctor's next time. I know I look like heck. I don't usually look like this. That's what I usually say because I know what they're going to be saying. I'm just weird like that, though. All right, tetany, continuous muscle spasms. They're like involuntary muscle spasms. So, like, when your eye twitches and stuff, think of something like that. That's what that would be. Usually associated with hypercalcemia, typically. All right, goiter. That's the first one you want to highlight here on this next page. Most common cause is that an iodine deficiency. And again, it's more common in women. And they show you a picture on the bottom of the page to the left. So it's the biggest thing there is knowing that it's not a tumor, even though it looks like one. Okay. Hyperthyroidism. I always tell my transcriptionists to be very careful with this. Hyper and hypo sound so much alike. Especially when the doctor's been dictating now, he's down at the diagnoses, they typically know it's almost over, so they rush a little bit. You would have to, I always say to double check the report for my coders, my medical front office, when you're going to look at these reports, just check the report. What is it about? You can usually see the symptoms in the beginning, like the history of present illness, why they're there, as to whether that's hyper or hypo, or go to the medications and just backtrack that way. Whatever they prescribed or whatever they're on, you can see if it's for hyper or hypo. So that's usually how I do like my checks and balances. So hyperthyroid, think of an overactive thyroid. Somebody usually loses a lot of weight. And then they talk about the most common form of it is Graves' disease. And they show you a picture of what this lady looks at the bottom of the page to the right with Graves' disease. Notice her bulging eyes coming out of the socket. They'll usually check the TSH level in someone. Hypothyroidism, that's an underactive thyroid. And that's, people, they tend to say it's uncommon, but I beg to differ. I seem to know a lot of people that have hypothyroidism. Usually a person will be really super tired, gain weight, and usually typical of not having enough iodine. Thyroiditis, I think you should be able to break down. It's basically a malfunction of the immune system. So inflammation like attacks the thyroid. They would usually give you hormone replacement therapy for this. So thyroid replacement therapy. Diabetes mellitus, which we just talked about on the board. Don't forget the NIDDM, the IDDM. So the first one, type 1, would be NIDDM, or they say IDDM, but I think they've got these, wait a minute, do they have these backwards? Oh yes, no, that's right. So IDDM and NIDDM, non-insulin dependent is the first one. Yeah, they have these backwards. I'm telling you. Wait a minute. Type 2. Oh, no, I've got this wrong. Okay, I'm having a brain cramp. Because I wrote my notes that I didn't believe that they were right. That's wrong. Type 1 is the lack of insulin. So you have to take insulin. You have to take insulin. So that's why it says insulin dependent. Whereas the non-insulin dependent, you're basically maintaining it on diet, exercise, and things like that. So it's a little bit better if you're going to have diabetes. And I know people that have the type 1, and I know Jamie's son, stepson has that. He has to take shots, and they have to monitor him. It's very, very scary, especially for children, as you can imagine, but for the parents of a child that, they have to manage their sugar better.
Student. She's
Do you?
14.
Oh.
She has it's attached to her monitor.
Yeah.
Under her leotard, she wears it.
Yeah.
And sometimes she has to leave during class because she has to test herself. She can feel when she's getting, but it's very interesting to start with her because they're trying to figure this whole system out too.
Yeah.
And to then have her parents leave and then it just be me.
Oh, you managing it.
I
hope nothing goes wrong. Yeah, and that is really scary. It's so funny because my daughter does. She's doing a play for her school, and her dance partner has a patch where where he, like you were talking about, on his stomach, and she has to jump on him. She's like, Mom, I have to jump on him and go, whatever, and whatever she's supposed to say. And she's like, I just am so afraid that I'm going to hurt him. And he's like, don't worry, I replace it all the time. It's not a big deal. And she's like, she couldn't get past it. She's like, I don't think I want to do this anymore. Just to get out of it, because it is. It's so sad. Anyway, this is important information to read through. This page don't take lightly, just because so many people have instances of this. We 2 people in one class just, mentioned it. So, all right, hypoglycemia, not enough sugar. They can call it low blood sugar is what they call it. When they say deficient, right? Did you just read that? The definition? What does it say? It's so he talks about the opposite would be the hyperglycemia. So can you please notice that they don't say hypoglycemia then hyperglycemia? So that's kind of like a term by itself. In other words, they should have it under hypoglycemia, but they don't. So I would highlight the hyperglycemia where the pancreas is making too much sugar. And then just make note, again, the hypopancreas is not making enough sugar. So then they go into hyperinsulinism, and as you can tell, I'm a little perturbed. They don't have hyper and hypo there, but hyperinsulinism, over secretion of insulin. That's that type 2 diabetes that we just saw. That's hyperinsulinism. Also want to point out to you, they don't use Roman numerals anymore. They used to. So if you ever go into old books or something, they used to use Roman numerals, and it's kind of gone away over the last few years. Acromegaly and pituitary gigantism, don't worry about. Cushing's syndrome, that one you may see. Your body basically has high levels of cortisol. Diabetes insipidus, that's again a rare condition. Basically, kidneys basically are starting to malfunction. And insipidus. Okay, growth hormone deficiency. It does not affect length. It's like, well, I mean, it's kind of considered a shortness thing, but the pituitary gland isn't producing enough of the growth hormone. So what somebody would do is they'd be put on a growth hormone replacement therapy. Hyperparathyroidism. What's scary about this is it causes your bones to become very weak and brittle. It's not enough calcium. Vitamin D, phosphorus, all your bone creating things. All right, hypoparathyroidism. It's an underfunctioning parathyroid. Again, another thing that has low blood calcium. This could be an inherited condition, but it is rare. So you know how I feel about rare conditions. You can study it or not. Hypopituitarism. Again, another thing that put you on hormone replacement therapy. I hope you're having a sense of a kind of a theme, if you will, with these. A lot of these, because it's the glands, they can give you hormone replacement of these. And you see over-the-counter hormone replacements, and you see other doctors now prescribing hormones, and then doctors are prescribing hormones. So I say doctors, other doctors, I use that word loosely. Doctors who've gone on their own, like age management type people, okay? Doctors who've left regular medical practice to help with just age management things. And so you're seeing hormone replacements there too. So they think they're pros at that. There's a lot of controversy over hormone replacement, so be very careful if you're going on it yourself. So polycystic ovary syndrome, you will see that one. Please highlight it. Women's sex hormones, estrogen and progesterone, are basically out of whack. These are benign masses, because it does talk about these numerous cysts, but they're benign. And it's considered one of the most common endocrine disorders for women. Primary adrenocortical insufficiency, also called Addison's disease, and that's typically what they say. So it's basically what's happening is you're not producing enough steroid hormones, which regulates how our bodies react to things, stress or stressful situations. Don't worry about progeria. That's rare. Again, that's a congenital thing, so we won't worry about that. Syndrome of inappropriate antidiuretic hormone basically causes water retention, but an oversecretion leading to hyponatremia. Okay, adiposity. Basically, that's the state of being fat. I don't even know why they have it in there because I have never seen that in a medical record ever. They will say obese, morbidly obese, whatever. They'll use those terms. I have never seen the quote unquote diagnosis adiposity or adiposity or however they say it because I don't know, never seen it, never heard it. Okay, morbid obesity, that one I've seen. So that one, they're talking about where your basic metabolic, your body mass index is and the level of it, which determines whether you're considered morbidly obese or obese. Does anybody else get a kick out of every time you go to the doctor's office, even if it's because you have the flu, they make you step on the scale? I am like, listen, especially if you have to go back 3 times because follow-ups. I'm like, seriously, I was here 2 weeks ago. I swear to you, I did not put 10 pounds on. Like, really, because it's really going to give me, I'm not going to want to come. That's what I keep saying. I actually threatened the lady last time. I'm like, listen, if you're going to make me do this every time, I'm going to find a new doctor because this is ridiculous. I mean, I had a cold. I don't need to check my weight. We can do that at home. All right, so 590, I'm not 591, you're not. Where are you? Oh, wow. That's totally neglecting my pages over here. Okay, so cystic fibrosis. Ooh, you'll see that one. I actually have a dear friend of mine. She's not a close friend, but somebody I went to high school with, and been able, thanks to Facebook, to keep up with her. And she's now on the lung transplant list, but she's got a young family, and it's so scary. And I don't know if she's ever going to get a new set of lungs, but it affects your lungs, your pancreas, liver, intestines. It affects everything, cystic fibrosis. Very difficult to breathe, and obviously it can lead to a lung transplant when it gets really bad, but it's unfortunate they make you go that long before you can qualify, so it's kind of sad. But anyway, so cystic fibrosis, you need to know it is an inherited condition. Dehydration, I think we all know what that is. Excessive water loss, basically. You're dehydrated, you're thirsty. Hypercholesterolemia, you should be able to break it down. But what's concerning about this is if somebody has this, it can lead to atherosclerosis or atherosclerosis. Hyperlipidemia. I'll give you one guess what that might be. No. But if you could break it down. It can lead to cardiovascular disease. So, we have to be careful of that. Hypocalcemia. Highlight that. Calcium, deficient of calcium. Make note of the abbreviation, calcium, Ca. Hypokalemia. That's potassium. K is potassium. Capital C, lowercase a is calcium. So make sure you make note of that as well. You need that. For muscles and, activities and things like that. It's a metabolic disorder, this particular condition. Hyponatremia. People who have liver failure, CHF, pneumonia, this is associated with this. Hypovolemia. You will see that one. Bleeding conditions, common causes, bleeding conditions, donating blood, all kinds of things. Excessive sweating, which I always thought was crazy. Severe burns. Ketoacidosis. This is very dangerous. It's a serious condition. It can lead to a diabetic coma, death, ketoacidosis, high levels of ketones. Think of it as poison in your blood, okay? So again, not enough insulin in your body. Phenylketonuria, that's the PKU. They do a PKU test. Genetic metabolic disorder again. They check this in newborns. Have you ever seen them do the heel prick test on a baby? That's what the PKU test usually is. But they'd go on a strict diet nonetheless. Don't worry about Tay-Sachs disease. That's a rare condition, so we won't worry about it. Pheochromocytoma. Oh, gosh, you really got some good words tonight. Again, it's a genetic cause to this. Don't really see it too often. They would just resect the tumor because it is a benign tumor. It's a high amounts of catecholamines and prolactinoma, most common type of pituitary tumor. It stimulates, but you think of it as it stimulates the breast to produce milk. So as you're reading it, think of that. Thymoma. Non-cancerous tumor, again, uncommon, so I wouldn't worry about it. Same thing with the next one, islet cell carcinoma. It's rare, don't worry about it. Malignant thymoma. I'm not going to say this one's rare because you see this with myasthenia gravis, which is another condition. So you might see this. They will, again, remove it with surgery again. Thyroid carcinoma. Most common types of thyroid carcinoma are follicular and papillary. And papillary is probably the more common of the two. So thyroid, that's just thyroid cancer. Under procedures, I just want you to pay attention to these, read these. In particular, A1C. We talked about that a while ago. Do you remember hemoglobin, learning hemoglobin? So hemoglobin A1C, and then they talk about the glycosylated hemoglobin, where they show you that it's HB A1C. So they talk about how you may hear it, A1C. Don't be confused. Really, they should have done it backwards. They should have put the glycosylated hemoglobin. See, somebody was a little lax when they got to the end of this book here. They should have put those two things first, because that's really what you'll see. Hemoglobin A1C. Fasting glucose is what they'll say. They won't say plasma. They'll say fasting glucose. Used to call it fasting blood sugar. Yeah, well, guess what? They still do. Okay? Just a fact. Hormone test, I think, is give me. Oral glucose tolerance test, definitely will see that, especially when they're dealing with concerned about diabetes mellitus. Radio immunoassay studies, they sometimes say just assay tests or assay studies, so just be ready for that end of that word to be by itself from time to time. Thyroid function test, you will see that one as well. Make note of the labs they're referring to, T3, T4, calcitonin. Total calcium. You'll see the word total with a lot of labs. Total bilirubin, for example, quite common. Urine glucose and urine ketones. Bet you can't guess how they get that. Yeah, urine. All right, most of these on the next group here, the endocrine procedures. Oh my gosh, again, another whole set of everything that they break down. I wouldn't do any more studying on some of these, especially the first two, break them down, don't worry about. I do want to point out something about the third one down, though. Endoscopic retrograde pancreatography. They will say ERCP, which is because what they're doing is they're putting the cholangio in front of it. So ERCP, the C stands for cholangio. Okay. And then break down all the rest of them. Don't worry about the other names for things. You'll be good. All right, abbreviations. Let me give you a few, okay? AC, again, what I'm going to say when I say give them to you, again, these are the more common that you'll see. So if that helps you, I'm glad to do it. ACTH, ADH, BMI, CA. This is not going so well yet, is it? I haven't bypassed any. CACF, DIDM. I told you that ERP, it's usually ERCP. I don't think I've ever seen just ERP. FBS, FSH. There, I skipped one. GH, HGH, IDDM, K, LH, NA, and IDDM. PCOS, PKU, T3, T4, TFTs, and TSH. That's it. Yay, you're done. Almost. Don't forget about your pharmacology section. Make sure you review those. Again, that's always good, important information for you. And again, next week, maybe a long one, maybe a short one. It's up to you. But I'm just going to tell you right now, it's the most important class that you attend. We will record it. It is always recorded and left on Evolve for you so that you can go back and refer to it. I want to make sure that you come prepared to ask me questions. I'm probably going to let you guys keep your mics open next week because I want you to be able to interject when you need to. Unless it's totally distracting, then I'll go back to what we always do. But we're going to talk about the three things: job, like where they are, how do you find them, because it's so different now than it used to be. We're going to talk about resumes. Tonight, I'm going to ask you if you want me to just see if you've got a good start. I'm happy to look at it, or you could ask me some questions. But really, next week, we're going to make some changes to it, okay? And how I say make changes to it, really what I'm going to do is I'm going to give you a lot to think about next week and how you might want to change what you currently have. And then at graduation, you're going to submit that. But again, next week will be jobs, interviewing, how do you interview, how should you dress, things like that, where to find the jobs, and then how do you graduate? Because isn't that an important thing? Like, now what? Do I get a diploma? Do I get a certificate? How do I go about getting that and obtaining that? So we'll cover all of that next week for you. This week, I want you to finish up your book, and don't you dare throw it away. I know you want to when you're done, but I want you to really take it seriously and get this information done. I think it should be really simple studying for you. It shouldn't be too much compared to most of those weeks. Think back to the musculoskeletal system, think back to the digestive. This should be a quarter of that, if that, okay? So do you have any questions before I let you go early tonight about what we're going to do next week, or maybe you want to talk about your resume a little bit, about what you have or anything, or do you want to just save it for next week? But I'll stay here as long as you want tonight, and then we'll, obviously cover it all next week.